I think we'll make a start. Good morning, everybody. I'm Paula Lorgelly, visiting at King's College until next week. And this is a session that I've organised. So this is one of the special organised sessions. So we have the beauty of just having one a day because they're considered to be so interesting. Hopefully that's the case. And so buoyant to kind of the work that we're doing at the moment. And I particularly put this together because I think we do a lot of economic evaluations and we look at efficiency. But sometimes it comes at the expense of equity when we do that. But it's not the case necessarily that health policymakers are always concerned with maximising health. And there might be other attributes, I guess, in their value set where they're interested in unfair inequalities in health and healthcare and financial protection. And so Richard, who will be our first speaker today, he's done some work in this area and it was published in Value in Health in 2017. So I suggest for those of you who are interested, go and read this paper. It is free to download, which is a rarity. And it looks at this notion of adding equity into the cost effectiveness analysis. And it was also awarded the prize at ISPOR for, was it the best paper in Value in Health last year. So the way this session is going to work is that, of course, we can all read papers and we all do read papers, but it's really nice to listen to people actually speak about their experiences. So we're going to have Richard about some key concepts and talk about the kind of methods of doing distributional cost effectiveness analysis. We're then going to have Susan speak about some examples in England that she's worked on specifically. We were going to have, is it Ule speak, but he unfortunately can't be here with us, but I'm sure Richard will reflect on the fact that some of his writings will appear in a book, so of a kind of Norwegian context. And then we'll have Ijeoma speak on the context in the South African program, where she's been doing some work on extended cost effectiveness analysis. The idea is that each speaks for about 15 to 20 minutes. I'll take some points for clarification at the end of each talk. The idea is also supposed to be seamless. We've got one slide set, so it all will just function perfectly. So points of clarifications. Questions in my mind start with either a D or a W, and they definitely end in a question mark. So it would be good if you want to ask a question, it is a question, at that point of clarification. And then at the end, we'll have more of a panel discussion, and I'll bring the three of them up, and we can actually make some kind of more grander statements, more questions, but more kind of consideration of your thoughts on where this is going. I have some starters for 10 in that respect, just in case we're still a bit sleepy from last night. But I'm pretty sure looking at everybody here, you'll all be engaged by the time we get to the end of it, and we'll have a really good discussion. So I want to bring Richard on, please.
Work? Oh, yes, great. Well, thanks so much for coming, folks. The room is, what? Not quite half full, but it's pretty good. For an equity session, that's pretty good. And in 2 years' time, it's going to be absolutely full, because this is a very exciting area of research. Finally, we've got some methods that can be used in practice. Finally, we can move equity from a sort of arcane methodological thing, all very exciting and philosophical, but actually, ignored in policy. Finally, I think we can actually start doing some useful analysis that HTA folk, priority setting folk can actually use. Decision makers can actually sit there and look at some evidence now that's useful about who gains and who loses, as well as looking at efficiency. So I think we're going to see a lot of growth in this area in the next few years. When we've already seen a lot of growth in the methods and it's starting to be applied. So I think it's an exciting area. So well done for coming here. You came to the right place. You saw it here first. The other thing to say is that in a way there's two bits of this area. There's the people who work mostly in high-income countries, Norway, Netherlands, the UK. They sit on these HTA panels, like NICE in the UK and so on, and they make decisions about new drugs. And their equity concern is usually about severity of illness or rarity of disease. or in the UK context, end of life, and so on. And what they do, they put a little weight on things. They do equity weighting. And a lot of people think that's all there is to it. That's what, distributional cost effectiveness, all it is putting a weight on things, okay? And in fact, they don't even do that really. They don't put a weight on the HALI or the QALY benefits. What they do is they just make the threshold a bit more generous, or, now, that's fine, and that's useful in those contexts, but there's a lot more to it, because what we really need to know is who gains and who loses from the decision you're making. We need to look at the opportunity costs, right, the who loses part, as well as the who gains part. And, if you care about end of life or rare condition or whatever it is, guess what? Some of the people who lose might have that characteristic as well. So you need really to think about not just your recipient population. You need to know you need to know the characteristics of the non-recipient population, the general population, who bear the opportunity costs, and you need to sort of carefully analyze the opportunity costs as well as the benefits. And when you start to do that, then you're drawn into the distributional way of thinking, where you've got these different groups of people with different equity-relevant characteristics, and you want to know who gains and who loses, and you want to sort of subgroup things out, and so on. And we can do that, we can do that. So we'll talk a little bit about how that's done now. Right. So the way that I sort of frame these things is, this is how decision makers currently see things. This is your cost per QALY. This is your average. This is the average efficiency benefit for the whole population. That's the white light. What we need to do is split that into the rainbow, who gains and who loses. Who's gaining those HALIs, who's losing them, right? Decision makers need to know, they need to split the efficiency light into the rainbow of the distribution. So that's what we're trying to do with this kind of work. The decision maker may make the same decision. Their decision may not change now that they've seen that information. They may, but at least we want to present the information, right? And we're not forcing them. We're not sort of, there's a sort of silly misconception about this field that the idea is to find this super weight that everyone's going to use all the time in every case, and the decision maker has to do that. That's ridiculous. The point of this is to provide information to decision makers about who gains and who loses, and then the decision maker decides how important that is, and so on and so forth. So we're just providing information. So that's why we're developing a training handbook in this area. We call it a handbook of equity informative health economic evaluation, because the idea is not to sort of determine, in a sense, we're not incorporating equity into the analysis. We're not sort of saying that instead of cost per QALY, we've got cost per super QALY. It's not like that. It's that we're providing information on who gains and who loses. So it's informative. Ultimately, the value judgment is not the value judgment of us, this analysts. It's the value judgment of the decision maker that matters. So the sort of equivalent, I see it, you can debate that. The way I see it, the sort of equivalent of a cost effectiveness plane in this field is what we're calling now the equity efficiency impact plane. You can call it what you like, that's just, but basically the idea is that the classical, cost effectiveness bit of the analysis is the vertical. That's you could call that the efficiency impact or the cost effectiveness impact. And one way of thinking that is, for example, net health benefit. It's when how many HALIs or QALYs you gain minus how many you lose from the opportunity costs, and that tells you whether you're improving health or not. That's sort of one way of thinking of cost effectiveness impact. But then we've got this horizontal axis, the equity impact, right? And so you can easily find cases. Oh, can I use this? Woo! Here we go. So that's what you want. You want decisions that, are efficient in terms of health. They produce more health for the population, but they also reduce inequalities in health, or they're improving equity in some ways that the decision maker cares about, okay? But here we are. You can have decisions which are very cost effective, but they're bad for equity. So then, and this is, one classic example is a lot of public health prevention type interventions. If you advertise to pregnant women to have folic acid, guess who's going to do that? It's going to be the middle class relatively affluent ones who do it, and so it's really great, it's very, very cost-effective way of improving health, but it actually will improve the health of the wealthier people faster than, so it harms equity in a sense, increases inequality. The same with a lot of prevention things when you need behaviour change. So you've got a trade-off then, and you might want to redesign your policy, right? So instead of just sending out a message to everyone, on the internet or something, you might want to start targeting social marketing towards more deprived groups. Or you might want to think of other ways of making sure that all social groups benefit from the policy. But then you've got trade-offs between the cost of doing that. It might be more expensive to have a special social marketing campaign. So you end up with trade-offs on the equity impact plane. And you want to, if you've got intervention that's here, you want to shift it, if you can, towards this quadrant. Get as much equity as you can out of the redesign without sacrificing too much of that lovely health gain that you've got. So you end up with trade-offs. And the opposite can happen as well. You can have interventions here where it's not actually cost-effective, but it really improves equity. So some policy for a disadvantaged group might be a bit more expensive, not as cost-effective as other policies, but you might want to do it anyway because it increases equity. And again, you might want to redesign it in various ways to make it more efficient. So there you are, you've got the trade-off quadrants, and then of course we have a lot of policies which harm health and harm equity. And if the decision maker is hell-bent on doing these policies, there you are, that's what they do. But all we do is provide the information. Okay, so this is the handbook that's in preparation. There's a very nice team of people around the world who are busily co-authoring these and leading these chapters, and hopefully it'll come out towards the end of next year. We hope to submit it September, October, but it always takes months and months for these publishers to get the thing out. So apologies, it'll take about a year probably before this is out. But there will be training exercises which will be free to download. The book itself will be the usual expensive OUP type thing, but the actual exercises can be done standalone. But yeah, you probably need to read the training thing as well. But the hope is that this can help people in a range of countries to start using these methods. We're often getting questions, well, how do we do this? How would I do a DCA in my country? And we can't provide all the support for it, so we're trying to get training materials out there. And we will be running courses. Various places around the world hopefully can use this to run courses in this area. And so we've made a lot of effort to get the book coordinated, and we've had endless discussions about terminology. Myself and Susan will smile at that. We've had endless discussions. But hopefully we're getting there now. We've got a product that will hopefully be useful. And obviously, as and when you get to see this, feedback would be great, because one day there'll no doubt be a second edition. We want to improve these methods and get this field moving. Okay, so that's the handbook. There we are. This was a meeting we had to launch the handbook. So there's Susan, my co-editor. This is Ula here, who sends his profuse apologies. Ula, he takes on too much, Ula. He's too busy. Maybe because he does equity, he's a very fair guy. He always says yes to things. He's on all sorts of commissions and panels. So, and he's not. He's a sort of philosopher economist rather than an economist philosopher. So, anyway, so he sends apologies. And the person missing there is our Tony Cullier, who's the other editor. But look, there's the other handbooks in this series. I think we'll end up with a red cover, but let's see. Maybe. Well, I think maybe grey, because we want to be kind of like battleship grey, kind of. Rigorous and robust. We're not just bleeding heart liberals, right? We want to be robust and get useful evidence for any policymaker, right? Right wing, left wing, whatever kind of policymaker you've got, will give you distributional evidence that you care about. 5 minutes left, right. Okay, so what's to say? So there we are. We have a glossary of terms. This is our definition of DCA. The point is it provides information about equity in the distribution and effects, as well as efficiency in terms of aggregate costs and effects. And as I said, the simplest form is when you've just got two groups, recipients and everyone else, and you weight them. However, you can do more complicated things when you break down who gains and who loses by these equity-relevant groups, and you can provide all sorts of other information here as well. And depending on the decision-making context, you might care about socioeconomic status, geography. I mean, in England, we have a north-south divide that exercises people. Ethnicity, obviously in some countries, ethnicity is a really big disparity that's really important, in the States, for example. Often one cares about severity of illness of people, and maybe gender, age. It could be indigenous, non-indigenous, and so on. Whatever the decision maker is concerned about, we can analyse the relevant distributions. So it's really the decision maker who tells us what, as analysts, what is relevant in their context. And why is it interesting? Some people say to me, "Oh, yeah, that it's just subgroup analysis. God Almighty, how boring! We've done, and you can't really do that anyway because the sample size is too small." Well, there's a bit more to it than that. So as I've said before, the opportunity cost distribution matters. It's not just the distribution of the effect in your trial, right? What about the opportunity costs? Secondly, equity is a general population concept, right? If you're a decision maker, you care about your whole population. You don't just care about HIV patients, fairness within that group, or fairness within heart circulatory disease patients. You care about your equity within your whole general population. So you need to model that, the non-recipients population as well. There's fascinating equity challenges when you're thinking about distribution, the classic Amartya Sen question, equality of what, you've got to think about that, between whom, summarized how. There's all sorts of interesting ethical challenges in these measures of equity. And there's the trade-off question. How do you trade off an efficiency gain with an equity gain? Very interesting technical and ethical challenges there. And the technical challenges, not just to do with sort of social welfare functions and welfare economics, there's also very interesting statistical challenges. So we think we've got a handle on how to get distributions of effects on the mean, conditional on your social economic status or ethnicity or whatever equity relevant variable you have. But when you're doing what's called ex post evaluation, when you want to care about the equity in the final outcome, let's say it's lifetime health, you need to look at the effects not only on the mean, but also on the variance and covariance with your equity relevant characteristics. And that's asking a lot of a trial, because normally we look at the effect on the mean, not the variance. So there's fascinating issues there. And of course, when you get into these distributions, you're in a world of complexity. And so, all the problems of, platforms, economies of scale and scope become important. And there's a lot of very interesting, complex modeling challenges in this area, which I won't go into. But just to say that it's kind of intellectually interesting as well as practically important, I think, this area. And I think, since I've got no time left, I think I'm going to skip the rest of it. I'm going to skip all this. And here's the list of the chapters. What else do I want to say? I'm going to skip all this. I think this is one final important thing to talk about. So this is a framework for thinking about the whole of distributional cost effectiveness analysis. What you want to do when you're doing this kind of analysis, you want to start off with the baseline distribution. Who currently has the best health and the worst health? What's the current situation in terms of equity is your starting point. Then you look at your decision compared with the alternative, and you work out the distribution of the benefits. Then you work out the distribution of the opportunity costs, and you put them together, and you find out, well, what's happened to the baseline situation? Thanks, Paula. So how has your baseline equity changed? And then you can do various indices to, social welfare functions here. But that's the core of it. It's working out who gains and who loses and how equity situation has changed. Then you can evaluate them. Now, a decision maker might just say, okay, thanks for the information, the list of who gains and who loses. That's all I want from you. I'm now going to make up my mind how much that matters. Or the decision maker might want to say, well, that's actually quite complicated, this great big splurge of distributional data you've given me. It's a mess. I want some analysis, please, of weighting this, of thinking through how inequality indices have changed and so on. So give me some analysis, please, to evaluate it. And we can do that in various more or less complicated ways here, of which one is direct equity weighting. That's the usual thing, but there's a lot of other stuff you can do as well. And finally, for every distribution, you need an outcome, which is the distribution of what. And so you can distribute health, and there's various measures of health you can use, of course. You can look at equity in health service delivery and equity in financial protection. So I think that's a useful way of, anytime you're doing one of these analyses, think through these steps in the analysis, just to be a bit more systematic about how we do things. I think that's really all I wanted to say. Oh, yes, well, have we got the list of the special interest group? Is that later, Paula? Okay. And here's a website. Some of the methods in this area are here, so that's a point of reference for you. But we will, once the handbook comes out, we will have better methods, resources, training materials, which will come. So that will take about a year, as I said. So this is our starting point for all this, but we'll gradually improve it. Thanks very much.
So can I just ask if there's any points, although he did skip some slides, some questions for clarification reasons? No? Do you know what price the book's going to be?
Usually it's...
All good retailers?
It's usually 30 or 40 quid, sadly.
I've got one here.
You applied this analysis anywhere for any specific countries or problems?
Well, so Norway, Netherlands, and the UK use the direct equity weighting approach for the equity relevant characteristic that's relevant in their country. It does vary by country. But the more complicated distributional things haven't, well, I would say that NICE are starting to think about it in our country for public health things. So, I mean, Susan will talk about how the analysis that she's been doing in the UK. And it's been, so the extended cost effectiveness folk on the DCP3 project, Disease Control Priority 3, they've done a lot of these. They call it extended cost effectiveness analysis. But whether it's been used in decisions yet, I couldn't say. I doubt it. But you know, the hope is it will be.
Any other clarifications or short questions?
Thank you for the interesting presentation, and definitely I'll be looking out for the book. I wanted to get your thoughts on what do you think would be the best way to incorporate this, the evidence from a distributional cost effectiveness analysis for policy making? Like, because now there is another additional angle of equity, so some policy that is cost effective right now but might not turn out to be favorable from the equity standpoint. In an ideal scenario, if you exclude politics, how do you expect this to be included in policy making for the benefit of all?
Very good question. I think Paula is whispering to me that we should move on, but that is a fantastic question, which we will come back to in the panel discussion.
Yes.
You've skipped forward 40 minutes. You're ahead of us, so thank you. That's crucial.
Remember that, and I'll come back to you. Yeah, I'll come up to you, but I won't run like that. Okay.
Oh yeah, Matt.
You mentioned the fact that some individuals may benefit more than others due to their income or educational characteristics. How do you try and strip that effect out, the fact that individuals themselves are part of the health production function, as it were, if you're using equity and health outcomes? Do you just accept that, or do you try and sort of separate that out at all with the analysis?
Well, if that's a fact on the ground, then that's a fact on the ground. But, I mean, this approach lends itself to redesigning policy. So if you can find a way of redesigning things to deliver it more efficiently for lower income groups, you know, if you don't have the right infrastructure in place for delivery in a remote area or something, you know, you can consider better ways of delivering it and so on. I think it highlights differences in delivery costs for different populations. And differences in benefit, yeah, which then you may or may not want to do something about, yeah. Thank you.
Thanks. So I think any other questions we'll just save to the end so we can have a bit of a broader discussion. So thank you very much, Richard. So now Susan's going to speak on a little bit more on how it works and actually, well, I don't know about whether it worked. We might come back to that at the end.
So good morning, everyone. So yeah, I'm going to talk about when we developed this framework, we aimed to explore and show how you could, through the process of economic evaluation, provide quantitative information about the impact on health inequality. And we did that by looking at how you might undertake an economic evaluation from start to finish and the steps you'd need to do, the additional pieces of information you'd need to include, and how you present and interpret the results. But I'm going to talk about a piece of work that we did with the National Institute for Health and Care Excellence in the UK. So they are a decision-making body in the UK that makes recommendations about interventions. They have a technology appraisal arm that makes recommendations about interventions within the NHS. And they also have a public health guidelines role where they appraise public health interventions and issue guidelines about which ones might provide good value for money. And so we began a piece of work, James Love Co. and myself from University of York with Becky Pennington and Leslie Owen from NICE. Becky Pennington's now at University of Sheffield. That explored a range of issues about how NICE could potentially use more information about inequality impacts of interventions in their decision-making process. That took the form of two elements of the project. The first was where we actually took an update to a smoking cessation guideline, and we undertook a distributional cost effectiveness analysis alongside that update to show that it could be done within the resource constraints of the typical NICE decision-making process. On the public health guidelines side of things, they don't actually commission economic evaluations for every single technology that they appraise. They have to prioritize, and they don't have a big amount of resource available for economic evaluation, but we showed it was possible within the constraints of that process. The second part of that project, they were interested to know whether the fact that these committees, the public health advisory committees, they are guided to already try and make some consideration of inequality impacts when they're making decisions about whether or not to recommend interventions. They don't actually see a lot of information about this, so they were interested in exploring whether we might be able to see whether it did appear to be influencing their recommendations. And we also, to do this, we also explored how far we could make some estimates of the health inequality impacts of the types of interventions they had looked at based only on aggregate data. So understanding that we wouldn't be taking individual bespoke distributional cost effectiveness analyses for all of these things, we said, well, you've got some economic evaluation information already. You've got the cost effectiveness analysis. So how far can we take that with aggregate and secondary level data? So we applied that to the NICE public health guidelines. The aim was to show the impacts on the health equity impact plane. Some of our discussions about terminology may become apparent here because I wouldn't talk about efficiency on the y-axis. I talk about net health benefit, because if you're a policymaker interested in pursuing a goal to improve population health and reduce health inequality, we can help inform you how to do that efficiently. So you could efficiently reduce health inequality. So it's that you can have net population health benefit on the y-axis and impact on some measure of, say, unfair health inequality on the x-axis there, and plot the interventions out on the plane. So we tried to do this for all of the interventions that had been subject to economic evaluation in the NICE public health guidelines. We wanted to see where they fell, to look at the pattern of the recommendations, and to see if there was kind of evidence that they were more likely to recommend things that both increase population health and reduce inequality, less likely to recommend these things, of course, but to see the trade-offs. We expected to see a greater level of recommendations in this win-win quadrant than we would in these trade-off quadrants, particularly looking at this comparison here. So in both of these cases, you have interventions that are cost-effective. They would have an incremental cost-effectiveness ratio below the NICE threshold. They would have a positive incremental net health benefit. But these ones increase health inequality, but while these ones reduce it, so they have an added benefit. So would we see a less likelihood of recommending something in this quadrant compared to in this quadrant? Similarly, at the bottom of the plane here, we've got interventions that are not cost effective, that have negative incremental net health benefits. Now, often this is not because they are less effective than the comparator. It might be that they are more costly and the opportunity costs are displacing health for other people at a greater rate than this intervention is providing. So it's very rare that we'd be evaluating harmful interventions or less effective interventions contexts, but that it might be just we would be foregoing too much health elsewhere. So would we see a greater likelihood of rejecting these interventions than these ones, where although they're not cost effective, there's this additional benefit in terms of inequality impact? So these are the steps that we took for this process. We looked through all of the NICE documentation related to each of these interventions, and Amanda Upton at NICE helped us to provide us with a list of all the interventions that had been subject to economic evaluation. So that was 134 interventions. We extracted information on the incremental costs and the incremental health benefits from the economic evaluation and on the size of the target population. So this would be people who are suffering from the disease that is targeted by the intervention. With public health interventions, it might be people who have a particular risk factor that is targeted, or in fact, some of the interventions themselves targeted explicitly disadvantaged groups, so people with low socioeconomic position. Once we'd extracted this information, we wanted to look at how we expected those direct health benefits, the incremental health benefits, to be distributed within the population according to age, gender, and from our perspective, we took socioeconomic status as our indicator of an equity-relevant characteristic, because within the UK, NICE is supposed to have pay regard to reducing health inequalities between groups, defined on that basis. In the constraints of this particular project, in terms of that distribution, potential distribution of the benefits, we were only able to look at the distribution of the disease of the risk factor, and we didn't have information on access to and utilization of the interventions. That's an extension that we are going to pursue in the next piece of work. We then took the incremental costs and converted them into health opportunity costs. And in a separate piece of research that we've done, we know a bit about how a marginal change in NHS expenditure affects health for different groups in the population defined by these same equity-relevant characteristics. So then we could get a distribution of net health impact and add this to what we know about the baseline distribution of healthy life expectancy in the UK between these types of groups and calculate our inequality measures pre and post the interventions to summarize the net health inequality impact of each of these interventions. So as I say, we used the information on the baseline distribution of health, and then we added the net health impact of these interventions. Now, the characteristic we were exploring in terms of health inequality was the association of differences in healthy life expectancy with socioeconomic status. But then we ordered the distribution from the least healthy to the most healthy. So this wasn't a bivariate comparison we were making. We didn't rank the population from the least disadvantaged to most disadvantaged and then plot their health. We ranked them from the least healthy to the most healthy and plotted their health. So we've got a univariate distribution of health, and that's the measures of health inequality that I will be presenting here. The distributions that we calculated are for the whole of the population of the UK, because that's where the health opportunity costs of NHS expenditure will fall. Obviously, we're working in a public health guidelines situation. Not all of the interventions are funded solely from NHS expenditure. We know less about how the health opportunity costs from other sources of expenditure are distributed within the population. But in a separate piece of research, we have found that the majority of the costs of these public health interventions are actually National Health Service costs. So if we think about smoking cessation interventions, those may be funded by local authorities. They're relatively cheap, but the big change in the incremental cost comes from avoiding cancers and avoiding NHS costs. So at least we know that the bulk of the costs follows that distribution, and we can do some sensitivity analysis around if there's different distributions for the local authority health opportunity costs. And then when we were in those trade-off quadrants, so if we saw something that improved health and reduced inequality, or something that improves health and increased inequality, or that reduced net health and improved health inequality, we explored how inequality averse you would have to be in order to prefer one intervention over the other. So we weren't intending to embed any particular value judgments in the process. So this just a kind of a map of the sources of data and how we combine that information to get the distribution of health benefits. And this is us plotting all of the interventions on the health equity impact plane. And we've separated them here into interventions that were recommended by the Public Health Advisory Committee and those that were not recommended by the Public Health Advisory Committee. So if you like, this is almost a best case scenario of how these interventions might impact on health inequality, because we only had information on the distribution of the disease, not on the actual utilization or uptake of the intervention at this stage. So this shows the maximum you could hope to achieve if everybody who is eligible for these interventions benefited from these interventions. The red dots, I don't know how well the colours come across in these, show interventions that were cost increasing. What we often find when we look at economic evaluations of public health interventions is that there's quite a few cost-saving ones in there that are shown by the blue triangles. This does have some implications for what we'd expect to see for the net health inequality impact of these interventions. If an intervention is cost-saving, then the saved NHS costs are used to fund other healthcare interventions, and we know that that's got a pro-poor distribution. And we know that NHS expenditure benefits disadvantaged groups to a greater degree than advantaged groups. So a cost-saving intervention will reduce health inequality by virtue of releasing those resources. That means the direct health benefits just have to not exacerbate health inequalities by more than this offset from the cost saving. From the cost increasing interventions, we know they will increase health inequality simply by virtue of displacing other activities because of this health opportunity cost. So the reduction in health inequality you see from the direct benefits has to exceed that for them to appear on the right-hand side of this plane here. We plotted out where the recommendations fell. So we totted up the number that were in increasing total health and reducing health inequality, the numbers that reduce total health and increase inequality. So these would be in the win-win and the lose-lose type quadrants on the plane, and then the trade-off quadrants. These estimates as well, I should emphasize, only look at the published incremental costs and incremental effects. There's no attempt here to correct for the level of the quality of the evidence base underlying these different interventions. But we identified that there was very few interventions in the trade-off quadrants. There was quite a lot of correlation between cost effectiveness and impact on health inequality. So we weren't able to actually make much judgment from this small sample size about how far inequality or assessments of inequality might be impacting on NICE recommendations in as far as the inequality impact matches our estimates here. We summed over all of the recommended interventions, all of the guidelines, and then we could add this on to the baseline distribution of healthy life expectancy in the UK to see how all of those recommendations combined could impact on the distribution of health if everyone eligible for them were to receive those interventions. So the potential cumulative net health impact, net health benefit, is at a population level, 23 million QALYs there. It would reduce the slope index of inequality, so the gap in healthy life expectancy between the most healthy person and the least healthy person by 0.44 QALYs. If we look at the value of the health inequality reduction on top of the value of the health gain, and to value this we can use a general population survey in the UK that's asked people how much they'd be willing to forego in health gains in order to reduce health inequality. We can use the Atkinson index in this case to convert that into a benefit of the health inequality reduction on the QALY scale. So we could calculate that you'd get an additional 5 million QALYs of worth of benefit, social value from the reduction in the health inequality on top of these 20, potentially from these interventions. So the actual value of these public health interventions appears much higher when you take into account their reductions in health inequality. And I've just plotted out a couple of things here on the plane. So we know that in the upper right quadrant here, I've highlighted we've got smoking cessation interventions. But as I mentioned, as part of this project, James and I also did an individual distributional cost effectiveness analysis where we were able to take account of uptake and access to smoking cessation, so differential uptake, and more advantaged groups are more likely to use these services. And we were able to take account of differential efficacy. If you provide a smoking cessation service to someone from a disadvantaged group compared to an advantaged group, the person from the advantaged group has a much higher likelihood of quitting smoking as a consequence of that intervention. It's more effective. So if you actually do the individual analysis, the smoking cessation model, once you take into account utilization and access to services, moves here. Take into account differential efficacy, moves over here. So if you're in the position where you have this differential efficacy you should probably undertake an individual distributional cost effectiveness analysis. This could be misleading. It's very straightforward to do the utilization within this aggregate approach. We just didn't have time to search for that information analysis. Over here, you've got older people in their own home. Our measure of health inequality was looking at healthy adjusted life expectancy. These older people already have accrued a fair amount of healthy life expectancy before any kind of intervention, and they own their own home. So this is quite a relatively advantaged group in terms of the distribution of health. So you see these patterns here emerging. So the approach based on aggregate data just takes these previous estimates of cost effectiveness and tries to show how they might be divided among the population according to who receives treatment. We only took into account prevalence and incidence in this analysis, and we're following them up with more information on actual access and utilization. But we know that the efficacy and benefit of treatment can be socioeconomically patterned, and taking into account this differential intervention impact is complex. But this type of approach might be quite valuable because prior to this, the public health advisory committees trying to take account of inequality impacts were having to do this all in their head. And it can be useful to go through these steps and provide the quantitative information to help map that out, because you can get very different impacts of interventions depending on how these things balance out. And it matters very much for some interventions, such as smoking cessation. But what we showed with the parallel project was if you're really concerned about health inequality impacts and you include that kind of approach from the outset, it's perfectly feasible to do these kind of analyses within the constraints of the NICE decision-making process. And then you could potentially do a full distributional cost effectiveness analysis if you obtained evidence that there was differential efficacy between groups. If there's limited or no data on these differential impacts, then the aggregate approach is going to give you a very similar answer to the more in-depth approach. And so perhaps you could just take that more simple approach in those cases where you didn't expect to see differential efficacy between these type of groups, and you can just use that quicker approach. So that's the end of my talk. Thank you.
Got some points for clarification for Susan. Got one hand all the way up there. Great running.
Just like to make this young man work out very hard. I'm just interested to what extent this group has either collaborated or looked at cross-fertilization with work done in the US, which is called extended cost-effectiveness analysis, which they tried to extend it in 3 dimensions, one of which is distribution. I remember telling them almost 7 years ago they're overdoing it and that distribution could be the right way to go, so I agree with you guys. But I'm just wondering to what extent there's been some collaboration.
So we've had involvement with people from that group. I would say that obviously we're working on the same issue, and the building blocks are exactly the same in terms of looking at where do the benefits fall and where do the costs fall of the different interventions. I would say perhaps there are a couple of distinctions. Obviously, we haven't taken into account financial protection, but this is a UK perspective. We have universal healthcare coverage. It's less of a concern in that sense. And then I'd say the final steps of the distributional cost effectiveness analysis part, they're not really distinct frameworks. We're looking at who gains and who loses, but there's more presentation of summary measures. So instead of just looking at who gains and who loses, there might be more of a summary calculation. But they're not different, they're not doing different things, they're very similar. And if you are interested in financial risk protection, the extended cost effectiveness analysis obviously is going to be a very useful approach. We've applied these methods in lower and middle income country settings, but obviously it misses out one of the potential benefits from providing those interventions.
Another question down here.
So when I look at your plane for the past decisions, as you said, there is a strong correlation between the quality gains and the inequality index. So would you recommend to do it every single time, only for on an exception basis? And in that case, how would you identify the cases for which there could be an impact that is not linked to the quality gain?
Yes, so I think you could probably start to identify based on the characteristics of the interventions and the patterns of the disease in the population where you would prioritize your efforts. But we've done a piece of work where we've looked at smoking cessation and at screening and brief intervention for excessive alcohol consumption. And it can be a bit tricky actually to kind of predict up ahead how these different gradients will actually pan out when they all counterbalance each other. So smoking cessation is, smoking is more prevalent in more deprived groups. Uptake of the intervention is greater in more advantaged groups. Efficacy is greater in more advantaged groups. And we see that actually interventions slightly maybe increase health inequality at the population level. This varies a lot by local setting. It looks very different in York to Sheffield, for example. With alcohol and brief interventions, heavy alcohol use is more common in more advantaged groups. Uptake of the intervention or access to the intervention was actually better in more disadvantaged groups. But that showed it to be inequality decreasing. And so when we looked at these two case studies and we explored them both and we looked at the gradients and fiddled around with them, we found it was quite tricky sometimes to predict where you really needed it. But I would say definitely where there's evidence for differential efficacy between groups, that would be one place to prioritize it. And if you didn't have that information, then maybe a more simple approach would be sufficient.
One final question just down here. Sorry, about 4 rows down.
I just wanted to check, would you always recommend using the difference in the index of inequality slope as your measure of inequality, or could you go more complex and have something like a concentration index, or more coarse and just have a difference in the mean between groups?
So in terms of what the inequality measure we would suggest to present, we use the slope index for inequality and the change in that in this particular case study because this was something that the people we were working with were familiar with as a measure of health inequality. What we tend to do when we conduct these analyses is estimate a range of measures. You might be interested in absolute reduction in inequality, relative inequality, you might be interested in shortfall measures, those kind of things. You can present actually a bank of measures, and if they all agree, then no matter what your particular inequality concern, then you can be pretty certain. But there are cases within this where it might appear that they've reduced relative inequality but increased absolute inequality, or vice versa at the margin. When we get to the point of trade-offs, when we're saying how much do you have to value that reduction in health inequality to forego health gains, we've been using social welfare indices such as the Atkinson Index or the Colm Index, and you can have shortfall versions of these as well. So they include an inequality aversion parameter that describes the extent of aversion to health inequality in terms of how much you'd be willing to forego improvements in health. Those kind of measures can be translated into QALYs, so it's an outcome measure that people understand, maybe a bit better than a 1% reduction in a concentration index, which might not have a very easy intuitive graph for how much that is worth. But I would certainly suggest to calculate a range of different measures, and it depends on the setting and the purposes. If you want to provide a full priority ranking of all interventions, then you need to somewhere value the trade-off between health inequality and health improvement. So these welfare indices are a useful way of doing that, but by no means the only way of doing that.
Thanks very much, Susan. Thank you. And we've now got our final presentation in the context of South Africa.
No? Okay. All right. Yeah. Oh, good. Great. Thanks. Great. Thanks, Paula. In the next 15, 20 minutes, I'll be talking through some of the plans we have to apply extended cost-effectiveness analysis for decision-making in South Africa. I'll state upfront that I'm by no means an expert in this field. These are ideas on how we intend to apply these methods, and you'd see why in a short while. So if you've got any questions about the technicalities of it, I'd say wait till the next iHEA conference in Cape Town. Or if Stefan is here, is Stefan here? Hi, okay, yeah, there you go. You can direct all your technical questions to Stefan. I'm sure he'll be able to answer them. Great. So I will use the case of introducing the rubella vaccination program in South Africa to illustrate why this might be important in a context of South Africa that has high health and wealth inequality. And it's all going to be at a very high level of how it might be applied. So, by way of background, unlike most of the high-income countries where you have established health technology assessment process, in South Africa, the application of economic evaluation in decision-making is still evolving. It's increasingly being used in making decisions about in informing resource allocation decisions in the public health system. For example, it's used for making decisions around new medicines to be included in the essential drug list, to inform recommendations of new vaccines to include into the EPI program and vaccination strategies, and also increasingly being demanded by the National Treasury for when budget bids are submitted to the National Treasury by the Department of Health. But the situation in South Africa is quite unique. It's with a population of 55 million and a GDP per capita of approximately $6,000. South Africa is one of the countries in the world with the inequality index. And so simply looking at maximization of healthcare benefits within a given budget doesn't quite cut it, because approximately 10% of the richest population holds 71% of the wealth, and you have the bottom 60% of the population holding only 7% of the net wealth in South Africa. The health sector doesn't perform any better. There's a sort of dual healthcare system in South Africa with a public health system that is under-resourced, very low quality of care, serving a population of about 84%, and then a private health system that has 4 times the health spend as you'd find within the public health sector, but only 16% of the population. Health inequality in South Africa is also quite pro-poor. Here's a study done by colleagues at the University of Cape Town, and they looked at a number of diseases and found that a huge number of disease conditions were concentrated amongst the poor, except for flu and diabetes. But then if you look at the trend suggests a pro-poor shift in the distribution of these diseases. It will be interesting to see what this profile looks like in today's today, but this is an old study done in 2009. So against this backdrop, the NHI, National Health Insurance Scheme, is being developed, hopefully will be rolled out by 2025, and a host of reforms is going to accompany this National Health Insurance Scheme. Health financing reforms are being proposed, a reorganization of the healthcare system, and a shift of a transformation in the way healthcare will be provided, shifting more to preventative and health promotion activities, the strengthening of the primary healthcare system, and also there'll be reforms affecting the way health services are purchased. And as part of this whole transformation, health technology assessment is expected to play an increasingly important role in the selection and prioritization of health interventions. Although the process is still being defined, it is expected that cost-effectiveness analysis and budget impact analysis will rank up there as in terms of evidence required in making resource allocation decisions, but given the huge health and wealth inequality in South Africa, equity considerations will also be important. And in fact, as stated within the NHI white paper published by the Department of Health in 2012, addressing the NHI, one of the aims of the NHI is meant to improve access to quality healthcare that is equitably distributed. So, we've heard about the distributional cost-effectiveness analysis, but the extended cost-effectiveness analysis is another possible tool for explicitly incorporating these equity dimensions into the decision-making process. It's called extended because it builds on cost-effectiveness analysis and considers other policy objectives that are not just maximization of population health. So we're looking at things around maximizing non-health benefits, financial risk protection, poverty cases averted, and importantly, maximizing the distribution of health and non-health benefits along some sort of equity lines. So, in very simple terms, the way the method works is that the population is divided into subgroups along some socioeconomic line that is of relevance to the decision maker. It could be income quintiles, it could be geographical regions, it could be gender, race. In South Africa, all these dimensions will be important. And then a model is developed to quantify health benefits and non-health benefits across the socioeconomic group of interest. So in the next few slides, I'll talk to you a bit more about how we might apply this method in making the decision about whether to introduce rubella vaccine into the EPI program. Rubella vaccination is currently not provided within the EPI program, but the Department of Health is seriously considering implementing it within the public health system. It's available for the private sector, but not within the public health system. So a little bit about the disease, because that helps to put these things into what we're trying to deal with into context. So rubella is a contagious viral infection that mainly affects children. It's seasonal in pattern and, with epidemics occurring every 5 to 9 years. Rubella infection in its own, particularly in children, is not a problem because it's not associated with any severe morbidities in infected individuals. But where the problem arises is when rubella infects pregnant women. It could result in fetal deaths, or if the fetus is carried to term, congenital birth defects affecting hearing, the eye functions, and cardiovascular defects. It's a condition commonly known as congenital rubella syndrome, or CRS. So vaccination programs are quite effective in addressing, reducing CRS, or eliminating rubella, and as a consequence, eliminating CRS. And the WHO recommends a number of strategies depending on whether the policy objective is to prevent CRS only, in which case you can vaccinate only women of childbearing age. But if, depending on how long the elimination, the goal is to eliminate rubella, you'd need to vaccinate increasingly larger populations within the country. We are currently trying to estimate the cost effectiveness of these strategies to inform the decision on whether it represents good value for money to roll out the vaccination program in South Africa. But evidence from high-income countries suggests that any of those strategies against no vaccination program will be cost-effective. But the caveat here is that these analyses have been done under ideal conditions. And it's important to stress that because introducing rubella vaccine requires very careful consideration because it could actually result in negative outcomes. A paradoxical increase in the cases of CRS have been observed where the conditions haven't been set right at the start. And the key epidemiological drivers that determine the success of a rubella vaccination program are these four factors listed here: birth rate, the disease transmission intensity, vaccination coverage, and the extent of random mixing between subpopulations within the society. So take the example of coverage, for example. To run a successful campaign, the coverage has to achieve, a coverage of not less than 80% has to be achieved across all regions and districts within the country. Suboptimal coverage could result in a reduction in the circulation of the wild-type virus, not enough to disrupt transmission, but what it does is it pushes the age of rubella infection upward. So looking at this graph, this is the age distribution of patients with rubella in South Africa. You see it concentrated more in the younger age group. But an introduction of rubella vaccination program that's suboptimal coverage can push this curve to the right, such that women get to the childbearing age without having been infected, and so are more susceptible to contracting rubella disease at that age, and obviously increase the risk of CRS cases if they fall pregnant at that time. This study by Metcalf and colleagues show quite nicely the interaction between all the variables, all those epidemiological drivers that I mentioned earlier. So they use a disease transmission model to work out the interplay between birth rates, vaccination coverage, and the force of infection, and how that affects the incidence of CRS with a vaccination program and without a vaccination program. So the horizontal lines show what the incidence of CRS would be in the absence of the vaccination program, and the curves show what would happen with the introduction of the vaccination program, depending on the epidemiology profile of the country. So with looking at this with a of 12 births per 1,000 population, it really doesn't matter how big the transmission intensity is. Introducing the vaccine will always result in a reduction in CRS cases. Things start to get a bit interesting with higher birth rates. So you can see that with higher birth rates and also with higher disease transmission intensities, you begin to see these humps appear. These humps kind of denote that shift in the age of transmission and also an increase in CRS cases following vaccination program. The only time it starts to make sense to introduce the vaccine in this sort of setting is when coverage is at least between 70 and 80%. And so you would expect that most low-income groups will fall within this profile, where in comparison to high-income groups that would experience lower birth rates and lower crowding and obviously lower disease transmission intensities, would fall within this group. I mean, your guess is as good as mine what the implication would be for a country like South Africa with huge health inequality in the distribution of health and wealth. So, I mean, and the guess is not quite far-fetched. So in this slide, I kind of present some of the distribution of birth rates and coverage across provinces in South Africa. There is some variation in the birth rates across the 9 provinces of South Africa. Not much, but enough to suggest that the impact of the vaccination program would vary by these provinces. And also, we find the same thing with coverage. So the rubella vaccine hasn't been implemented, but we can use the coverage of the second dose of measles vaccine, which is administered at 12 months, as an indication of how well the rubella vaccination program would fare, given that both vaccines will be given as combined doses. And we see, again, some variation across the provinces, and importantly, none of the provinces actually hit the 80% mark. The situation within provinces are quite heterogeneous. For example, you see provinces like Western Cape and Gauteng that are the most wealthiest provinces, but you have the super rich living alongside the super poor. So what we would really like to do is is to divide the population along income quantiles and estimate the health benefits and non-health benefits that accrue to each of these population groups. Of course, there's the added complication of as opposed to, looking at geographical areas where individuals are to a large extent contained, looking at socioeconomic or income groups might require, have an added complication of trying to account for the random mixing of vaccinated and unvaccinated individuals. Okay, so just to summarize, in the context of South Africa, looking at just health, looking at just efficiency gains or having a policy objective of maximizing population health on average using available resources might not necessarily be it has political implications, never mind the health and socioeconomic implications. And a method, an approach like the extended cost effectiveness analysis could be very useful in answering questions around what subgroups would be the highest, would the highest health or non-health benefits be observed in, and will the introduction of a new health intervention exacerbate socioeconomic inequalities in the distribution of health and wealth. However, it's worth noting that there is, with the extended cost effectiveness analysis as opposed to the distributional cost effectiveness analysis, there's currently no way of aggregating all these dimensions of benefits into some kind of index value that would allow policymakers rank across interventions on what intervention to implement or not, and there isn't any decision rule that allows the policymaker decide what might be acceptable or not, what trades-off might be acceptable or not between an intervention that maybe improves one dimension but doesn't do very well in another dimension. But maybe we don't need a decision rule. Maybe we don't need to be able to aggregate these dimensions into one index. Perhaps it's sufficient to present these sorts of evidence alongside economic evidence and clinical effectiveness evidence to policymaker, and let them appraise within the iHEA process what might be best to implement within the country. Okay, I'll leave it here. Thank you very much.
Have we got any specific questions for Ijeoma before I bring the panel down? No? Okay. Can I ask two things? The panel to sit over there, please. And then can we have some lights over there as well? That might be more difficult. Excellent. So questions then for the panel. I had some. We've got one from the floor that I'm going to come back to. So they've seen mine, so they're already prepared answers for them, so that's not the easy approach. So I'm going to go with Rachel.
Rachel Morton, University of Sydney. A lot of the evidence in terms of efficacy comes from randomised trials, and randomised trials can collect indicators like age and sex commonly, but they don't often collect those other factors of social disadvantage that Richard talked about. So I'm wondering, in the advent of more pragmatic trials and registry-based trials, what advice, perhaps Susan, you might give to clinical trialists to enable us to capture information about differential efficacy to then use in distributional cost-effectiveness analysis?
Well, yes, I think that it's true that clinical trials don't often collect this information, or in fact, even if they collect it, they don't really report analyses in this way. So we might want to encourage more of that. But I would say clinical trials are probably not the best setting to capture this kind of information. I guess it's similar to the distinction between efficacy and effectiveness, that a lot of these differences will play out when it's delivered more in a real-world setting as opposed to a trial setting. So, in fact, the clinical trial might not give you a good idea of what that looks like. We've certainly used taking advantage of quasi-experimental methods to look at, to try and extract this type of information from observational data. We are looking more at combining economic evaluation. There's been some sessions in this conference already with impact evaluation and making use of those kind of methods and maybe routine electronic health records in a higher income setting to try and look at those types of information. But it really needs to be considered at stage of study design. If you're interested in that as an impact, then you need to be designing it in from the start. So as we have proliferation of, the extended cost effectiveness analysis of these methods and more acceptance of the importance of inequality concerns, maybe people will start to bring it in from the study design stage, and design studies, that gives us more of the information we would like.
And one quick addendum to that, if you do want to be doing this in a trial, read the consort equity guidance in the British Medical Journal last year. The group of us have got guidance on how you should be reporting these things consistently so that people can come back later, maybe 10 years later, and pool it in a meta-analysis and have consistent set of, because it's reported awfully, even though, they often do collect this, but they just don't report it properly. It's a mess.
Kunal?
Kunal Shah, Office of Health Economics. It's really great to see progress being made on this topic, so I want to congratulate the presenters for taking this work forward. My question kind of touches on the second of the discussion points on the screen. The presentation says that the DCEA framework doesn't embed value judgments, but it relies on sensitivity analysis to understand how decisions might change depending on the decision maker's level of inequality aversion. And I guess for this to make any practical difference, they do have to be inequality averse. So do we have any sense for how inequality averse decision makers are, and do the panelists think that there's any value in trying to estimate that empirically?
So, there is a clear policy mandate for people to consider reduction in health inequalities highlighted in UK policy documents. We were asked by NICE to look at it. They are very interested in impacts on inequality. So they're concerned about that. And Richard and I think Matthew Robson is here and others actually did a general population survey in the UK to see whether people would be willing to forego improvements in health to reduce health inequality between rich and poor groups. And similar studies have been carried out in a US setting and in other settings around the world. And there's some interesting work being done from Erasmus, I think, looking at not only aversion to inequality, but risk aversion and prospect theory and things like this, and bringing in these other values, societal values, into the decision-making process. So there is empirical work into that. I would say there is definitely a steer from policymakers that they're concerned about it. But what we found is they haven't been put in any tricky spots necessarily where they have to make a hard decision about putting their money where their mouth is, I guess.
And I'll go to a question, but I can see someone in the audience, I'm looking at Emily here, who actually sits on a decision-making committee who might want to reflect on that. I'm just going to give you a heads up. I'm going to ask you to reflect on that from an Australian context. But question at the back.
Hi, Virginia Wiseman from London School of Hygiene, Tropical Medicine and the Kirby Institute. It is really a great session, thank you. I'm just thinking about benchmark values. Have you been able to start to explore what stakeholders might feel is a okay trade-off between equity and efficiency?
Again, I'll follow up on that again. I guess the numbers that come out, so it's, I guess, stated preference techniques that have been used to extract these types of levels of inequality aversion. And the numbers that have been coming out are much higher. So the measures that we've been applying in terms of summarizing the impact on the distribution as a whole, so taking into account improvements in the mean and changes in inequality, were developed in the income inequality setting, so measuring those kind of things. And there's been actually very little exploration. I mean, I think the Atkinson Index probably has been around for decades now, and people just kind of stick a default number of about 2 in a lot of the analyses they're doing when they're looking at income inequality. There's been actually a study done, and it puts the value as much higher when you're looking at health inequality at around 11 for this parameter. It doesn't have a nice intuitive interpretation, but when you apply that to the baseline distribution of healthy life expectancy in the UK, what it suggests is that the general population in the UK that answered that survey would sacrifice 2% of all the QALYs in the quality adjusted life expectancy distribution to achieve perfect equality. So everyone has the same quality adjusted life expectancy, which might be regarded as a bit high. What we can do is this threshold analysis. So we can show how far you'd have to be willing to make the trade-off. And so I guess decision makers can see if they're above or below. But as we say, it's not used in practice. We can't actually test to see if there does appear to be a benchmark or a revealed preference for health inequality compared to health improvement.
Ijeoma, what about you? I mean, do you think the South African decision makers, are they just talking the talk here, or do they actually care?
Well, they definitely do care about equity, but it's not in terms of what the trade-off might be. I think it's not very clear what it will be. It's something. This is a method that hasn't necessarily been introduced to them. We're still grappling with trying to build capacity and getting them to understand the application of economic evaluation, and indeed, that's taking on root in South Africa, and it's been applied for decision making. But the way equity considerations will be integrated into that decision making process is still unclear, but it's definitely going to rank up as one of the huge considerations given the huge inequality in South Africa.
And my experience in this is that the public get it eventually. If you spend half an hour explaining it to them, you do get some understanding and interest and some answers out. Policymakers love it when you do these things, they enjoy it, but they're very reluctant to be pinned down, and they'd be embarrassed if the numbers got out. So, yeah, it's a tricky one. But I think it's an iterative, so cost effectiveness threshold, guess what? We had no method, we just iterated towards it. I mean, we've got this number, £20,000 per QALY in Britain, but goodness me, you can go down to 13,000 if you talk to Carl Claxton, you can go up to 45,000 if you look at actual decisions, you can go up to 100,000 if you look at willingness to pay. So we don't really have a very clear, stable number for even something as basic as that. So, let's give it a bit of time before we worry too much about exactly what the trade-off is. Let's do sensitivity to start with and iterate.
I think we're very whetted our appetite for Cape Town. 2 years, we'll be able to answer it by then. Got a question up here.
Aidan Hollis, University of Calgary. Thanks for the great presentation. It's really interesting stuff. One of the great things about cost effectiveness analysis is that it makes all the diseases, treatments, whatever, all kind of comparable. It puts them on a simple measure where you can actually compare across. Equity considerations, on the other hand, aren't like that because there are an infinite number of different equity considerations that you could apply, fair innings stuff, the orphan drugs and equal access to having a treatment, all the socioeconomic ones, ethnicity. There are a lot of them, and trying to weight those things, of course, is more or less impossible. And we do have a standard way of doing that in dealing with tax and transfer systems, essentially. We already have a fairly efficient way of addressing those kinds of problems. So I'm just wondering how you begin thinking about when should health authorities say, we're going to try to deal with all these equity considerations and do an end run around sort of tax and transfer, or do you think that the people in health systems don't trust the people in finance who are setting tax and transfer decisions?
That's a lovely question. I mean, that's a classic public finance question. You have the efficiency branch of government, one of which is the spending department's health, making the efficiency decisions, and you have the distributional branch of government's tax and transfer, worrying about equity. So that's a classic economic way of thinking about this. The problem with that is that you'd be waiting a long time for the tax and transfer system to be perfected. And also the distribution of health might be different from the distribution of income. You might have concerns that are health specific. And it just turns out that health decision makers do care. We've heard from Susan in the UK context, but decision makers are concerned about these distributions of financial protection and health. So they want information. But I think the serious issue is what you said about the generalizability of these measures. You know, do you have these very program-specific equity measures which you then can't compare? And so I do think there's a role for the broader equity measures that Susan, for example, was using. She has a univariate distribution of healthy life expectancy at birth, where you adjust for as many factors as you can when you're predicting that out. So Susan's got socioeconomic status and gender in there, but you could imagine a whole bunch of other characteristics in there. So it is possible to create, it's called the unfair health inequality approach, Fleurbaix and Schockhart. So you can create these quite generic measures of health, and the trick then would be then to use the same measure across contexts. So I think we can move in that direction, but with the caveat that decision makers want their own specific equity measures for their own specific context. So I think there's going to be a serious tension there, but it's a really important issue.
Yeah, I agree. I think each context would have to develop what matters to them. For example, financial risk protection might not be a problem for one country, but might be an important equity consideration in another country. And so maybe what is needed is for each country to develop a reference case for deciding what, the equity dimensions to consider.
I would say that in terms of using the health sector as a kind of redistributive tool in society, I mean, it's certainly the case that if you want to reduce health inequalities, allocating healthcare, secondary healthcare especially, is a hugely inefficient way of doing that, and you should redistribute income. That's going to get you a lot bigger bang for your buck. But there is clear indication that even given that, within the health sector, they would be willing to take into account health inequality impacts. And then you see it a bit in terms of the resource allocation formula. So there was a revision of how people distribute funds within the UK to different sections to spend on NHS, and they brought in a measure of deprivation. At one point it keeps coming and going as to whether that resource allocation formula will have an additional equity component to it, so a weighting that you would actually spend more in certain areas simply because of the level of deprivation, not the increased need for healthcare in that setting. So there is evidence of that redistribution purpose there. When I said people hadn't investigated the income inequality, they have to a degree. You can take a kind of optimal taxation approach and look at the implied redistribution. That's very difficult with healthcare expenditure, so we haven't achieved that yet, but something you could do.
Can I go back to that question that we got at the start? Do you remember what it was? Sorry, because I don't.
Thank you so much for remembering. Yeah, hello everyone. I'm Ritika Kapoor from National University of Singapore, and I'll repeat the question which I had before. I wanted to gather thoughts about how distributional cost effectiveness analysis can be used to redesign health policy decisions, especially in situations which are tricky, because you mentioned that, many times they haven't faced the tricky spots yet. For policy questions where, it's cost effective, but if you include equity, it might not be the favorable one. But it's still a health concern, and keeping all political factors aside, what would be the ideal best case way of using the results for policy implications? Thank you.
And can I just add to that? So obviously within the room and within the world, we have HCA agencies in different spaces. So, we have the Australian model, which is the oldest, And we have some of the newer ones that are happening in South Korea and in Saudi Arabia, for example. And so some of them are starting to adopt, some of them are already in a kind of a very processed place. And some of their healthcare systems have different data as well as different ways of making decisions, whether they make them. So can you also reflect on whether you think you need to be more mature in your system to do this, or actually if you're about to embark in using HTA in your country, whether actually this is where you should start?
I'm sure if Ula was here, he would explain how they actually are doing this in Norway. In terms of the level of evidence, how mature you need to be in your HTA process, we are in dialogue with NICE, quite mature process, and they're thinking of bringing this in. We're also doing a package of work in Malawi, helping them with health benefits package design, and we're applying these methods to show how you might design your health benefits package differently if you also had a concern for health inequality. Obviously, the amount of data is more constrained, so it's much more tricky, for example, to get that baseline distribution of healthy life expectancy, but you can do it, and so we're doing it in both situations. In terms of how it would actually be used to inform different decisions about policies. So with the information that we've provided on some of these things, if we take smoking cessation as an example, there's a big concern at NICE and other places that the restrictions and the reductions in local authority public health expenditure, that people simply stopped providing smoking cessation services. And it can inform a range of things around that. The utilization data or the uptake data that we had actually wasn't just based on how likely you as an individual were to use them if they were provided. It just looked at who actually got that. That reflects restrictions in availability. So you can use it to inform a different number of decisions. It might be that allowing local authorities to make these decisions about whether or not to provide smoking cessation independently, and when their funding is restricted, now we know that's exacerbating health inequalities, so because of the patterns in uptake. So you could say, maybe we should fund this nationally, do something about that. Maybe you would say, actually, we're not that bothered about removing smoking cessation services as we previously considered to be, because we know they're exacerbating health inequalities. Maybe they're prioritizing correctly, and they're doing things that actually are helping disadvantaged groups more as a consequence. There's a range of different things you can do, and you can even use some of this information to advocate for not cutting those budgets, for example, to say that maybe with these public health expenditures, we're underrepresenting the value by only looking at the net health benefit, that there's additional value from this impact on health inequality as well. So there's a range of ways you could use it for policy decisions.
So do you need a mature process? Probably, because the clue's in the title. It's distributional cost-effectiveness analysis. So if you don't have cost-effectiveness analysis to start with, you can't really do the distributions. However, there is a caveat to that. So my colleague Mick Dadasaria went to Delhi to try to help them set up a sort of kind of Indian NICE. It didn't go very far. But because it's a massively fragmented, complicated system, and they don't have a mature HTA process, it doesn't really make sense to do classic HTA in their context. But what he did tell me was that actually they're really just interested, the decision makers were just interested in what happens to the bottom, I don't know, was it quintiles or was it caste, I can't remember, but the bottom fifth, let's say, of people. They just want to know what's the effect on them for delivery services. That would be their equity question. And it was almost more important. They didn't really care about total qualities. They didn't really know what that meant. What they were interested in coverage and risk protection and health gain among the bottom fifth. So you could have a situation where you don't bother with the vertical bit of the equity impact plane. All you care about is the left and right bit. You could, I mean, yeah.
Ejeoma, how have you found it in South Africa then?
Yeah, well, in South Africa, I don't think you can separate the politics out of this decision because of the history of South Africa. I mean, most decisions made implicitly already take those kind of equity lens in decision making. And so maybe having a method like this, given now the drive towards implementing a HTA process that is sustainable, this is an opportunity to formalize that process of making decisions that explicitly incorporate equity into the decision making. But in a country like South Africa, and maybe Karen might have something to say about that. The general feeling is that equity would trump efficiency at most times in decision making. So I don't think for South Africa you can separate the politics from this decision. Yeah.
I'm mindful of time, so I'm going to wrap it up by saying I'm interested in this. Rich is obviously interested in it, Ijeoma and Susan, and Naomi Gibbs. Is Naomi here?
No, she couldn't make it.
Okay. Is thinking of proposing a special interest group so we can have this discussion in more detail and potentially meet again in 2 years' time in Cape Town. I mean, I put your hand up if you learned something today. Always the success story, I think, of one of these sessions. Put your hand up if it's whetted your appetite and you think you want to learn some more. You know,
Right, I'll expect all of you to sign up then if you're telling the truth with your hands.
I think what's important is that we need to keep having this conversation. And so I look forward to seeing you all in Cape Town. Join with me to thank the presenters and thank the audience for a really good discussion.
Thanks.